All right, welcome back, MRCOG candidates. Today we're diving straight into a super high-yield explainer. We're going to break down the essential clinical pathways and those highly testable statistics found right inside RCOG Green-top Guideline number 45, Birth After Previous Caesarean. Let's just jump right in and distill all this evidence down into exactly what you need to know for the exams.
So here's our clinical roadmap for today. We'll start with 1, antenatal care and counseling, then move to 2, suitability for planned VBAC, followed by 3, VBAC versus ERC, the data. After that, we'll hit 4, Interpartum management of VBAC, 5, conducting planned ERC, and finally, 6, special clinical circumstances.
Okay, let's kick things off with Section 1, antenatal care and counseling.
Look, before we even think about counseling a patient, we absolutely have to get our terminology straight, right? Appendix I of the guideline lays it out clearly. Planned VBAC simply refers to the intended mode of delivery for a woman with a prior cesarean who's planning to deliver vaginally. ERCS stands for elective repeat cesarean section. Nailing down these baseline definitions is absolutely crucial because the entire shared decision-making process balances perfectly between these two specific pathways.
You know, it's actually pretty wild just how prescriptive the guideline is when it comes to documentation. The RCOG strongly recommends using a very specific VBAC versus ERCS checklist, basically a clinical care pathway, to make sure we're hitting best practice. We have to ensure that shared decision-making is thoroughly documented in the notes well before the planned delivery date. Oh, and here's a massive exam trap. If the patient opts for an ERCS, you absolutely must document a clear plan for what to do if labor starts before her scheduled date. It's a critical safety net, and examiners love to test on it.
Moving right along to Section 2, Suitability for Planned VBAC.
So, who actually gets the green light? The crucial point here is distinguishing our standard suitable candidates from the absolute red flags. A planned VBAC is totally appropriate for a singleton pregnancy, cephalic presentation at 37 plus 0 weeks or beyond, with a single previous lower segment cesarean scar. Simple enough, right? But on the flip side, you got your absolute contraindications where VBAC is strictly forbidden. We're talking a previous uterine rupture, a classical cesarean scar, or any other general absolute contraindication to a vaginal birth, like major placenta previa. These red flags are absolute must-knows.
Now picture this. You're in the clinic, and a woman with 2 previous lower segment cesarean sections asks if she can attempt a vaginal delivery. It's a classic MRCOG vignette. So, can women with 2 or more prior cesareans actually be offered a planned VBAC?
Well, surprisingly, the answer is yes, but, and this is a massive but, there are some major caveats. The guideline explicitly states they may be offered VBAC, but this scenario demands immediate senior involvement. A senior obstetrician has to do the counseling, laying out the specific risks of uterine rupture and maternal morbidity. And if they do decide to proceed, labor absolutely must be conducted in a center that has suitable expertise and the resources to pull off an immediate surgical delivery. So it's definitely not a standard pathway. It requires a highly individualized risk assessment.
All right, Section 3, this is the big one, VBAC versus ERCS, the actual data.
When a patient sits down and asks, "Doctor, what are my actual chances of a successful VBAC?" we need to anchor that baseline success rate firmly at 72 to 75%. That is our standard counseling figure for a woman with 1 previous cesarean and 0 prior vaginal deliveries. But wait, check out this statistic, 85 to 90%. If the patient has had a prior vaginal delivery, especially a previous successful VBAC, her success rate absolutely skyrockets to 85 to 90%. In fact, the guideline points out that a previous vaginal delivery is literally the single best predictor of a successful VBAC, and it independently drops the risk of uterine rupture. So always ask about prior vaginal births when you're taking a history. Of course, we've got to talk about the risks too. You have to punch in this critical number, 0.5%, or about 1 in 200. That is the exact risk of a uterine scar rupture during a planned VBAC. It's an absolutely mandatory part of the informed consent process. To truly master shared decision-making, we need to look at these risks side by side. Notice how VBAC slightly increases the risk of uterine rupture, 0.5% compared to virtually 0, or less than 0.02% for an ERCS. VBAC also carries a slightly higher risk of neonatal hypoxic ischemic encephalopathy, or HIE, sitting at 8 in 10,000 versus less than 1 in 10,000 for ERCS. But hey, ERCS is not a free pass. Look at transient respiratory morbidity. ERCS bumps this risk up to 4 to 6%, compared to only 2 to 3% for a VBAC. This data right here is your ultimate tool for balanced patient counseling.
Okay, moving to the labor ward.
Section 4. Intrapartum Management of VBAC.
The second a VBAC trial is actually underway, these mandatory protocols kick in. Number 1, secure IV access, send a full blood count, and get a blood group and save. Number 2, and the guideline hammers this point home, we must start continuous electronic fetal monitoring for the entire planned VBAC, starting exactly when regular uterine contractions begin. And number 3, we have to assess cervical metric progress at least every 4 hours. Why? Because a failure to progress or a sketchy CTG are your prime clinical warning signs of an impending uterine rupture.
Heads up, because here is a massive exam trap. If a VBAC labor needs to be induced or augmented, that risk of uterine rupture jumps by a massive 2 to 3-fold compared to a spontaneous labor. 2 to 3 times higher. The guideline highlights that women absolutely must be informed of this spike in risk. Plus, any decision to induce or augment means getting a senior obstetrician involved to clearly map out exactly when we would pull the plug on the VBAC trial.
Let's flip the script and look at this surgical route. Section 5. Conducting planned ERCs.
Conducting a planned ERCS is all about strict chronological adherence to keep morbidity down. First up, timing. ERCS should be done after 39 plus 0 weeks of gestation. That minimizes the neonatal respiratory morbidity we talked about earlier. Second, antibiotics. They have to be given before making the skin incision. This was a really big new emphasis in the 2015 update. And third, postoperative care. Every single woman undergoing an ERCS needs to receive thromboprophylaxis based on the existing RCOG guidelines, no exceptions.
Finally, Section 6, Special Clinical Circumstances.
So these are the gray areas. The guideline explicitly advises a really cautious approach for VBAC in several high-risk scenarios because, frankly, there's still a lot of uncertainty around safety and efficacy. We're talking about post-states pregnancies, twin gestations, suspected fetal macrosomia, a history of antepartum stillbirth, or if the maternal age is 40 or older. If you see any of these factors pop up in an exam vignette, or frankly sitting across from you in clinic, your clinical alarm bells should definitely be ringing. They prompt careful, highly individualized, senior-led, multidisciplinary planning.
So as we wrap up this explainer, I want to leave you with something to chew on. How are you going to integrate these exact statistics and risk profiles into your very next patient consultation? Because mastering Green-top Guideline 45 isn't just about memorizing some percentages to pass the MRCOG exams. It's about confidently wielding this structured evidence to empower women to make the absolute safest, most informed birth choices they can. Trust the data, guys, and best of luck with your studies and your practice.